Hi, this is Jamal, and in this video we are gonna discuss the inferior alveolar nerve block technique. Inferior alveolar nerve block technique, which is commonly termed for IAMB. It's also termed the mandibular nerve block, but it's not accurate. It is a useful technique for quadrant dentistry, which means you will anesthetize the teeth from molar to the incisor. A supplemental block, which is called the buccal nerve. We will discuss this later. Area anesthetized in the mandibular nerve block. The mandibular teeth to the midline include molars, premolars, and the anterior teeth. And the body of the mandible, the buccal mucoperiosteum, which is the mucous membrane anterior to the mandibular first molar. The mental nerve responsible for this area. Anterior 2/3 of the tongue and the floor of the mouth, and the lingual soft tissue. The lingual nerve is responsible for these parts, and we will discuss how to anesthetize the lingual nerve along with the inferior alveolar nerve. We have three landmarks you have to keep in mind, which is very important for successful anesthesia. First, the coronoid notch, which is the greatest concavity on the anterior border of the ramus, as shown here, and the tergomandibular raphe. And the last one, the occlusal plane of the mandibular posterior teeth. And we will gonna discuss how you can get benefit from these three landmarks. But now you have to memorize these three landmarks. Needle penetration occurs at the intersection of 2 points. Point 1 falls along the horizontal line from the coronoid notch to the deepest part of the tergomandibular raphe as it ascends vertically toward the palate. Point 2 is on vertical line through point 1, about 3/4 of the distance from the anterior border of the ramus. This determines the anterior-posterior site of the injection. We will clarify these points in this picture. When you pull the cheek with your finger, a horizontal line extends to the deepest part of the tergomandibular raphe. This is the horizontal line. And the vertical line, it extends from the occlusal plane of the mandibular teeth, mandibular molars, which intersects with the horizontal line. And this will give you approximately the intersection or the injection site at the intersection between these two lines. Bone must be contacted. The average depth of penetration is 20 to 25 millimeter, approximately 2/3 to 3/4 the length of long dental needle must be inserted in the tissue. If bone is contacted too soon, less than half the length of long dental needle. The needle tip is usually located too far anteriorly, laterally on the ramus. To correct this, just withdraw the needle slightly but do not remove it from the tissue, and redirect the needle until more appropriate depth of insertion is obtained. The needle tip is now located posteriorly in the mandibular sulcus. Just withdraw your needle slightly without complete removal of the needle from the tissue, then redirect the needle into more appropriate position or depth until the bone is contacted. As shown here, if the needle is too far anteriorly, this will lead to the premature contact. And you can notice this when you see 2/3 of the needle is visible. This means wrong technique. Over insertion can be noticed with nothing visible. You can see nothing here. The whole needle is inserted inside the tissue. This is also a wrong technique. You have to withdraw the needle and reinsert into a more appropriate position. When bone is contacted, withdraw approximately 1 millimeter to prevent subperiosteal injection. Aspirate. If negative, deposit the 1.5 milliliter of anesthetic over a minimum of 60 seconds. Slowly withdraw the syringe, and when approximately half of its length remains within the tissue, re-aspirate. If negative, deposit a portion of the remaining solution, which equal to 0.1 ml, to anesthetize the lingual nerve, which is responsible for the interior 2/3 of the tongue, a floor of the mouth, and the mucoperiosteum adjacent to the molars. After approximately 20 seconds, return the patient to the upright position and wait 3 to 5 minutes before commencing the dental procedure. Signs and symptoms of correct anesthesia or successful anesthesia: the numbness of the lower lip and tingling or numbness of the tongue. But these two indicators are not reliable. The most reliable indicator is when no pain is felt during dental therapy. This is the best sign that you gave a successful anesthesia. Do not deposit local anesthetic if bone is not contacted. Never. The needle tip may be resting within the parotid gland near the facial nerve, which is the cranial nerve, the 7th cranial nerve, and a transient paralysis of the facial nerve is produced if solution is deposited. Avoid pain by not contacting bone too forcefully. We can summarize this technique by these points. First, the site. You can easily determine the site of injection by two lines. The horizontal line, which extends from your fingertip to the deepest part, just here, to the deepest part of the coronoid notch. And the second line, which is the vertical line from the occlusal plane of the mandibular molars. The intersection of these two lines will give you the site of injection. The gauge of the needle used most commonly is a 25 gauge. Bone must be contacted after insertion of about 2/3 of the needle. If the bone contacted after insertion of only 1/3 of the needle, this means a wrong technique. We have to withdraw the needle and reinsert. If the whole needle inserted with no contact with the bone, this is a wrong technique. We have to withdraw the needle and reinsert it in another position. You always have to aspirate to avoid hitting the vessels. After giving 1.6 ml of the cartridge, you have to withdraw the needle, and when it's half visible, you have to give the remaining 0.1 ml of the cartridge to anesthetize the lingual nerve, which is responsible for the interior 2/3 of the tongue and floor of the mouth. If you're still confused about some points, I'll try to clarify it more. Thanks for watching, and don't forget to subscribe to my channel.